We're going to be talking today about using health data in research and doing so responsibly. My name's Laura Forty. I'm the Patient and Public Involvement and Engagement Lead for the Pioneer Programme, and I'm joined today by Susie Gallier, our Technical Director. So I will begin the presentation and take you through a few slides about how we involve members of the public in decision making around health data research, and then I'll hand over to Susie, who will talk to you about the more technical side of things. So just a quick overview of what the session today will cover. We're looking at using health data in research, keeping the public's best interests front of mind, involving members of the public in how we make decisions about how health data should be used in research, and when we've decided that it is appropriate to use health data for research, how we do so safely and securely, making sure that we don't put any individual or group at risk of harm. So it's really important that we treat people's data, health data, respectfully. There's no question that there's huge potential for using health data in research, and how health data can help us to answer really important research questions that ultimately will have an impact on patients' outcomes and people's lives. But we are tasked with doing so responsibly and being really careful with that health data. I think the general public have certain expectations around how their health data will be used, and those are completely understandable. So when you visit your GP surgery and have a conversation with your doctor, for example, you may share things with them that you wouldn't share with friends or certain family members. So I think the bar is set quite high for privacy and care taken around our health data. So as a research programme that is looking at making use of that health data for other purposes, we have to be really careful, and we want to kind of meet those expectations set out by the public about how careful we should be with people's data. To ensure that we have the richest data set possible and to really make the best use of the data that is available, Pioneer has chosen to use an unconsented data model. So that means that we don't have to ask for individuals to consent for their data to be used in our data set. We are legally allowed to do that. We've got ethical approval to do that. In fact, it's not that uncommon, but it does place even greater importance really on how we involve representative patients or representatives of members of the public to give us their opinion about whether we're doing things with patients' best interests in mind. So it is possible to opt out of the way that we use health data. So if you think about, you may have seen in recent years campaigns around organ donation and how that has changed in recent years. So at the moment, it's taken as read that your organs can be donated when you die, unless you opt out of that. And actually the same is the case for health data research. So your health data can be used in research unless you choose to opt out, and that national opt-out is available to everyone. We've talked about it in other sessions and other webinars, and we'd be happy to answer any questions about that at the end if you've got any. But as I say, because we're not asking individuals whether they're happy for their data to be used in this way, it's really important that we've got the pulse, our finger on the pulse of public opinion, that we're reaching out to members of the public who represent that population, and we're talking to them regularly about what they understand in terms of health data research, how their data is used, and what they feel comfortable with for how their health data is used. So listening to and understanding that public voice has been a real priority for Pioneer right from day one. So from before our platform was built to collate the data in, from before our policies, procedures and processes were put in place, we were talking to members of the public. We were reaching out and seeking their opinions. So earlier in the year, earlier in 2020, we conducted a survey. We did this in the hospital foyer before the global pandemic hit, when we were able to interact with people face to face. And we spoke to over 300 patients, hospital staff, hospital volunteers, visitors, and we asked about what they knew about health data research and what they felt about health data research and how they felt about their health data being used in research. And then we set up a series of public workshops. So we brought people together face to face to talk a little bit more about those survey findings. So we spoke to members of the public at that point so that we could dig down a little deeper into the things that we'd learned from the survey and to understand a bit better what that meant for patients and members of the public. So just to very briefly go through a couple of top lines about what we learned. This graph on the left here shows us what we found out from the survey when we asked what people thought their health data was used for, and the blue bars show where somebody believes their health data is used in that area already. The orange bars where people don't think their health data is used. So you can see a trend across from left to right. More people had an awareness of their health data being used for those things on the left and fewer for those things on the right. So for their own healthcare, that was fairly commonly understood. For other things related to the NHS, there was the majority of people had already thought that their data would be used in that way. But in terms of sharing with academics or private companies doing research around medical devices or new drugs, for example, less people were aware that their data was being used like that. But actually, when we asked people what they would be happy for their data to be used for, especially considering that data is anonymised, we saw the blue bars take over here, really. So people were generally happy with their health data being used in more ways than they realised that it was being used at the moment. So that was a really interesting finding from that survey. And when we dug down into those discussion groups, these are a few of the things, just a couple of examples really of things that we heard. We heard that patients were quite positive really about their health data being used to help doctors to make better decisions for their patients, if it could be used to help anybody else. But they raised some valid points about clarity around who was using the health data for what purpose, whether people with lived experience of particular conditions were being consulted, were being talked to, and concerns about how easy it might be to identify an individual within that data set. So listening to all of those things, the Pioneer programme formed some key principles. So I'll quickly run through what those were, and those principles have been used since then to shape the direction of the Pioneer programme really, and to inform the decisions we make about the ways that we work. So these things were important to members of the public, that data access decisions were made for public good, so with the public's best interests in mind, that they had community support, that we were involving members of the public in those data access decisions, that the data stayed close to the NHS because public trust in the NHS is pretty strong, and that we were talking openly and transparently about how we are using health data. So that's partly why we're doing this webinar series, because we really want to put ourselves out there and be in a position where you can ask us questions, and we're happy to answer and to discuss openly kind of what we're doing. So that was a really useful outcome of that piece of work, and as I say, it's impacted on what we've done ever since. So we talked a little bit about some work that Pioneer's done, but actually there are numerous studies on public attitudes to health data research that have taken place over the years. And although there are differences over time and there are nuances between populations questioned, so for example, younger populations are usually more open to their data being used for a variety of different purposes, than older populations. And that's perhaps no surprise, because that generation have grown up with Facebook and Instagram and sharing their lives much more openly on things like social media. So perhaps privacy issues are not so much of a concern. Yes, so there are differences between those studies and depending on who you talk to, but there's also some very strong common themes that come through, and so those are represented here in the word cloud at the bottom. So we have brought out things like patient benefit, public involvement, ensuring that data sharing happens on a need-to-know basis for an agreed purpose only, that we're being diligent about who we're sharing data with, and we're doing those background checks. And Pioneer very much lives by all of these principles kind of outlined below, and it doesn't differ in that way from what other people have found when they've talked to members of the public about what they're comfortable with. So just to bring you on to one really specific example of something that we've done off the back of that learning and the work that we did with the surveys and the workshops earlier in the year and the principles that we put in place, it was very clear from those from the work that we did then that it was really important to members of the public that they were involved, or that some patients and members of the public could be involved in data access decisions. So we've set up a data trust committee, which is made up entirely of patients and members of the public, who review and advise on every single data access request that comes through Pioneer, and their opinion is taken really seriously. So as a group, they can recommend to either approve data access or not to approve, and if they don't approve because they don't feel comfortable that it's in the public's best interests, then that access request goes no further. So they've got a real responsibility, and we are really listening to our patient and public committee members through the work that we do with the Data Trust Committee, and that's something that I think we're really proud of as a project team. So I've talked to you, that brings me to the end of my slides really. I've talked to you about how we involve members of the public in the decisions that we make and how we're listening to members of the public and to patients. So I'm going to hand over to Susie, who will talk to you a little bit more about the technical side of things. So once we've made a decision that it's appropriate to share data with a particular researcher, how we do so in a way that protects patients and public identity, and that shares that data in a secure and safe way. So Susie, I'll hand over to you now.
Thank you, Laura. That was a great explanation of how we use data responsibly by involving patients and members of the public. So for the second half of this webinar, I'm going to focus on the technical aspects of responsible data sharing, from how we mask data, that's how we sort of hide identities, to how we sort of transform data ready for our researchers and we move that into our secure Pioneer environment. And as we go through, I'll explain what all these things are, and I promise that any technical diagrams and words I will explain as they appear. Next slide, please. So why do we need to mask data? Well, it ensures that only people who need to see the data have access to it. And by that, we protect the identities of data and people by shielding confidential fields such as date of birth and postcode. It also helps us to reduce data breaches, which is a must-have, and actually under law we're obliged to do so. So the techniques we have to do this are called pseudonymisation and anonymisation, and I'll talk to this in the next slide. So the first thing to say is that anonymisation and pseudonymisation are not the same. And even amongst data experts, people sometimes get the two interchanged and incorrect. So with anonymisation, the keyword is unrecognisable to anyone, even yourself. So you shouldn't be able to see a data set and actually recognise yourself in it. And also, the other key part of this is that it's irreversible. Once that analyst has made the change and made that data anonymous, it can't be changed back. But with pseudonymisation, what we actually do is we take those identifiers such as postcode and date of birth and we mask them. So we hide it with some very long code, but it does mean that what we're able to do is we can reverse that. And the reason we'd want to do that is, for example, if we wanted to update the data set in a month's time, we can actually unmask that so that the researchers don't get to see the sensitive data such as your date of birth, but the analysts who need to update it are able to do that. And really that's where the key legal distinction comes, because pseudonymisation is still classed as personal data because it can be reversed and we can identify you when we reverse it, whereas with anonymisation we can't. Next slide. So if we click through, so from the point you're admitted, and we have our example patient here, one that was available for us to use. I promise I haven't been going around the wards taking pictures. So we have our patient and we start to capture data. And so if we click through, we then start to see that the clinicians have what we call, these are computers on wheels, or as we friendly call them, cows. So we actually are able to enter the data in and start to track that. And so once it's entered in, next, please, we have what's called our sort of clinical record, our electronic health record. And this is where doctors, nurses, and healthcare professionals can access your data to treat you. So this is the sort of thing you'll be familiar and you'll see as you've come into hospital. You'll see all these sort of notes being taken. But how does that look to a researcher? How is that responsibly, from our point of view, dealt with? We don't see it like that. So if we click through, I promise this is another one that looks horrifying, but I just wanted you to see how it looks for us. So we actually put everything in what are called tables. And so everything that represents you is put into this table. And so we're able to sort of start joining up bits about you. So for example, we have a person table. This is the table that really we are, from a responsibility point of view, to protect your data. That's the one that has the most identifiable information. It's got your name, it's got your gender, it's got your ethnicity, where you live. So this is the bit where we will be transforming and focusing most of our effort on. All of the other things just tell us a little bit about what happened to you whilst you were in hospital. So for example, did we have any surgery, perform any surgery on you? Were you, did you have any diagnoses, etc.? But it's all done in this way. So actually what you imagine it to look like from the front end, when you get to the data, when we're actually transforming it, it does look very, very different. Next slide, please. So I did promise not to be technical, but I do feel, and I promise you all, that I'm not going to go through this start to end. You'll be very relieved. But I think it is really important when we talk about extracting data. I think people often have this feeling that we just simply take and create a spreadsheet or create a very quick database. What you actually see here is that whether we're taking data from our own hospital or we're receiving data from West Midlands Ambulance, for example, we have to go through a lot of processes. So as Laura touched on earlier, you can opt out. If you opt out, we remove your data straight away, so it doesn't go through any of the processes. But hopefully what you can see, there are some orange boxes there. That's us checking the data. It's checking the quality of the data. Have we got any 500-year-old patients in there that we know just couldn't possibly exist? That we're not passing that research information on to be used inappropriately. So we know that we fix anything that we're concerned about within that data. Also, when we pseudonymize and de-identify, we're following industry standard here. We're making sure that everything is done according to how the principles are laid out for us to do. But each of these steps is, can take days in its own right. But so hopefully, as I say, I'm not going to go through every single step. If you've got questions at the end about these steps, I'm very happy to take them. But it is simply a case that there are different people checking the data. It's not just one person. There are many, many people touching this data. Next slide, please. So really bringing this, drawing this towards the end, we've now created this data. We've removed opt-outs. We've de-identified you. And this is where the researcher is allowed access to this data. And the need to put this somewhere safe is absolutely paramount. And that's where Pioneer, not only from our data perspective and what we're able to provide from the data side, we're actually wanting to do the whole thing. So we will provide a secure area in the cloud for users to access that. But in order to provide that area, we have had to go through a very rigorous process. And I've actually invited in a government tester to come in. They've tested GCHQ. So we went for the hardest hitting company to come and try and knock our door down, and we had a really, really good report back. They were very happy it's secure, so nothing can be moved onto this environment until we have external validation and it's continuously checked. We have many, many rigorous processes for people to access. So we have user authentication, we have things that are called firewalls, which are just basically a very secure way that it checks your computer address, so it knows you can't just access from anywhere. And we have all of these processes in place. And so what that means is that our data isn't going off to many different directions. The researchers are coming to us and accessing the data in one place, which means from the start of the journey to the end, when that researcher is doing their analysis, it is in a secure environment. And finally, last slide, Laura. So really, we have you, the patient and the public, at the heart of everything we do. And certainly from my perspective with my team, we are very, very aware this is patient data. And in terms of how we de-identify with the legal processes that we follow, my team have to have a retrain every year on information governance and have to pass a test. We are audited. So everything about this is incredibly process-driven, legal-driven. But really, at the core, what we want to do is provide really rich, longitudinal healthcare data for researchers to help acutely unwell patients in the future with research, so that we can innovate practices and we can innovate new ways of working. So thank you very much for your time today. I appreciate this is an absolute whistle-stop tour of something that is, I mean, at the heart of everything we do, but very happy to take questions. Thank you.